begin, it is my absolute pleasure to introduce to you Dr. Isabella Garti. Dr. Garti, I should say, is a midwifery researcher with the Mali Wardaguga Institute for First Nation Birth Rights with Charles Darwin University in Australia. So, Dr. Garti, take it away.
Thank you very much, Bronwyn. Happy International Day of the Midwife to everybody joining. And I'm so glad you could make time to be with us today. We are failing women at birth. And the reason is that postpartum care remains fragmented, inconsistent, and women are not just receiving the same continuity of care they received when they were pregnant. In the next 30 minutes, I will show you how midwifery can offer a different path, one that improves outcomes while advancing equity, access, and women's rights. Next slide, please. So this is the outline of my presentation. Next slide, please. All right. So preeclampsia remains one of the leading causes of maternal mortality and morbidity. Yet, as the literature shows, preeclampsia itself is under-researched, it is under-discussed, is inadequately managed, and particularly in the postpartum period, the statistics are really dire. And so in the next couple of slides, we'll take a brief overview as to what preeclampsia is and all the nuts and bolts about postpartum preeclampsia. Next slide, please. All right, so preeclampsia by definition is a complex medical pregnancy complication. So in preeclampsia, what is happening is that a woman who was previously normotensive at the start of pregnancy has developed hypertension at or after 20 weeks of pregnancy. And oftentimes with preeclampsia, there's multi-system involvement. So preeclampsia affects not just the mother, but also the baby. Take a quick look at the statistics on my slide and see how disheartening it is. We are losing on a yearly basis 50,000 women. Let that sink in. 50,000 women. These are sisters, these are daughters, these are wives, these are your friends. This could be anybody you know, even your next door neighbor. Even more shocking is the fact that 500,000 babies or fetuses around the world are dying as a result of preeclampsia. And so we see that with preeclampsia, the effects are quite dire. So early diagnosis and effective management are critical. However, it still is a challenge around the world. Again, the burden of preeclampsia is quite high in low and middle income countries. Within these settings, women oftentimes could be in rural or remote places and are often marginalized. And so these disparities actually reflect deeper structural inequalities. And some of these inequalities are driven by poverty, by racism, and geographic isolation. And these persist even sometimes in high income countries like Australia. Interestingly, the urgency fades once the baby is delivered. So what I want us to take away from this presentation is that just because we have helped the woman get to the finish line, she's had the baby, it doesn't mean that her risk of preeclampsia has ended. Preeclampsia can actually affect a woman during pregnancy, during the birth, or in the postpartum period. That's how serious it is. Next slide, please. Preeclampsia is also not just the woman's problem or the woman's thing. It actually affects or places a strain on the entire health system. When a woman gets preeclampsia, what it means is that she's going to be really sick. Now, this woman will need to be hospitalized, and it's going to come at a cost to her and her family. She's not going to work. She's going to have a lot of hospital bills to pay. Even when medical care is free, the drugs and all of those things, sometimes she has to pay out of pocket. Again, it places an enormous strain on the health system because this woman will require a longer hospital stay. So that bed is going to be occupied for much longer. At the same time, her baby may also require NICU services. And so you know that for a baby to be in NICU, even one day, it's so expensive. So in low and middle income countries, this is an extra cost that we can't really afford. The burden of preeclampsia is also not shared equally. As I mentioned, it is much more higher in low and middle income countries where access to timely quality maternal care is often shaped by geography, income, or the social context of the woman. also in these settings, women have much poorer outcomes. And for example, eclampsia, which is a very severe form of preeclampsia, oftentimes occurs most commonly in low and middle income countries. When I used to be a midwife practicing in Ghana, I would see lots of women come in fully having a convulsion in the postpartum period. And so these things mean that we really have to be mindful that the impact of preeclampsia extends beyond the mother, extends beyond the pregnancy or birth period into the postpartum period. And so urgent attention has to be drawn onto this particular thing called postpartum preeclampsia. So in the next slide, we are going to yeah, and was next slide, please. So when we say postpartum pre-eclampsia, we are talking about a situation where a woman develops high blood pressure and signs of organ dysfunction after giving birth, usually within the first few days and sometimes up to 6 weeks postpartum. Postpartum pre-eclampsia can occur to a woman who has had a very normal pregnancy. And so what happens is that because this woman had a very normal pregnancy, she wasn't at risk of anything, her birth was fine, we oftentimes do not place priority on these women, and so we don't identify it early enough, and it leads to much more severe outcomes like eclampsia, as I just mentioned, stroke, or even organ failure. Data on the prevalence of de novo postpartum hypertension. I mean when I say de novo postpartum hypertension, I'm talking about women who are developing hypertension for the very first time after they've had a baby. We are seeing that it is actually quite common. And because the woman has just had a baby, she's breastfeeding and she's tired, the symptoms that she's presenting with, usually headache, tends to be misinterpreted. So everybody will say, oh, you just had a baby, you are tired, you need to rest, but we don't delve further to see what is happening underneath that sort of layer. And so all of these things make postpartum preeclampsia really tricky to navigate. Next slide, please. So postpartum preeclampsia can affect any woman really, including those without a prior history of hypertension, but the risk is higher if the woman is obese, if she has diabetes, if she already had hypertension or kidney disease. Again, we are also saying that it is also more common in women who have multiple pregnancies, women who are above 35 years, and in women who are oftentimes marginalized or refugee and migrant women who live in or women who live in low resource settings where continuous care may be limited. Interestingly, if a woman had like epidural anesthesia, for example, or she was given vasopressors or like ergot derivatives during her labor or birth, she's not at heightened risk of postpartum preeclampsia. But I also want to make a disclaimer here that preeclampsia itself is a disease or a complication shrouded in mystery. We still do not know the exact cause. We still do not know all the mechanisms underlying it. And same goes for postpartum preeclampsia. So the research is still ongoing, and every day we are discovering newer things about it. Next slide, please. So how would this woman present? There's the early presentation or the early onset, and there's also the late onset. For the early presentation, usually a day or two, up to 3 days after birth, this woman will suddenly start complaining of headaches. So be mindful that a mom who has just had a baby who complains of headaches really needs to be listened to, and we need to go further than just say, oh, you're tired, have a glass of water or take a Panadol. It could be that her blood pressure is going or is becoming skyrocketing high. This woman may also have other neurological symptoms like visual changes and also may report epigastric pain soon after delivery in those first 2 to 3 days, one to up to the third day. For the late onset here, usually we don't even pick this because the woman has been discharged and she's long gone. But this can occur from about the 7-day postpartum to about 3 months after. So see such a wide gap. And this woman may also report very commonly headaches, visual changes, and epigastric pain. But I also want us to note that when women just walk in, they come in and they just say, something is off. I don't feel quite right. They need to be listened to because a woman knows her body more than any other person. And so sometimes the only symptom is that the woman may just walk in and say something doesn't feel quite right with her. She just doesn't feel okay. And we really need to probe further to find out what is happening to the woman. Unfortunately, for the vast majority of women in low and middle income countries, and about 20%, I dare say, of all women will present having a full-blown convulsion. So this woman, we didn't pick any of the signs and symptoms. She would just have a full-blown convulsion and will be brought in. And it brings my mind back to when I was a midwifery student, sometime in 2006, I believe. And they brought in a woman who had just had a baby. She was about 6 weeks postpartum, and she was brought in dead because she had a seizure in the middle of the night. Her partner was away and nobody saw her. So meaning that there were many opportunities we could have identified this, but it was missed. Next slide, please. So what do we know about pre-eclampsia itself? Because that will help us understand the biological mechanisms of postpartum pre-eclampsia. Pre-eclampsia itself, like I said, is a disease shrouded in mystery. Currently, most of the theories revolve around the placenta. So it is believed that once the woman has had the baby and the placenta is removed, that should herald sort of like a reduction in the symptoms and should start the path to the cure. However, what is interesting is that all of the changes that have occurred in the woman's body will not just go away because she has had the baby. The effects continue to linger. And so preeclampsia has triggered these biological changes that will linger for a very long time. Preeclampsia is associated with heightened vascular sensitivity to angiotensin 2, which persists into the postpartum period. At the same time, all of these vascular changes that occurred in her endothelium will not just go away. So all of these changes and the hormonal changes that she's currently experiencing means that she's at a higher risk of developing high blood pressure in the postpartum period. And so we don't fully understand the mechanism, but these are the main factors that are causing her blood pressure to remain elevated or for her to have lingering hypertension after she's delivered. But when we come to de novo hypertension, it is something different that is occurring, and we'll talk about it in the next slide. All right. So postpartum de novo hypertension, here we are saying that this woman is developing hypertension for the very first time after birth. In fact, it is more common than we think. So a study was done by Parker et al. In 2022, and they found that about 27% of women will develop hypertension for the very first time after they've had a baby. As to why they are developing it for the very first time, we can't tell. But the key thing to remember about this cohort of women is that they oftentimes present late. Why? They were fine. They had a normal birth. We've discharged them and they've gone home. They may move in with their mother-in-law for the postpartum period, or they may relocate, or they may not even attend our facility any longer and go to a different health facility. And so these women are frequently underdiagnosed. And without routine monitoring or without that continuity in care, we will miss them and they'll continue to develop complications like stroke or eclampsia. But just hold on to that thought because we'll come back to this later and we'll look at how this gap in care is exactly where midwifery-led models can make a real life-saving difference. Next slide, please. So the focus of my presentation today is not to give you or to sort of like go into the nuts and bolts of the management of postpartum preeclampsia and all of that. That's not the focus of my presentation. It is actually to draw our minds to the fact that Midwives can fill in that gap in the postpartum period. Midwives can and do continue to make a huge difference in the postpartum period. But just to have an overview of what postpartum preeclampsia management is about, management for this woman requires coordinated but also a stepwise sort of approach that begins with accurate assessments to be able to make that accurate diagnosis that she's actually having postpartum preeclampsia, followed by timely stabilization and then initiating that sort of first line appropriate treatment for this woman. It also involves us clearly identifying the pathways by which we can escalate her care when the condition is becoming severe, and also providing that sort of structured postnatal follow-up upon discharge and making sure that this woman continues to receive what continuity of care. So this is how the management of postpartum preeclampsia looks like. However, I also want us to recognize that in most guidelines for the management of preeclampsia, the postpartum period just has like a sentence or two. So the guidance is quite limited. And so without comprehensive guidance, people are just left to think that, oh, we've brought her over. She's had the baby. Mom, baby are fine. And so it ends there. And so even as we discuss all of these things, when we get towards the end, we'll talk about the influence of policy and guidelines and how we can make this better to ensure that women get quality care that they deserve. Next slide, please. All right, just take a look at this study that I pulled up and see what I have highlighted really largely. Women continue to report that in the postpartum period, the care they receive is inconsistent, and sometimes some even receive no care at all. Once the woman has had the baby, the focus almost shifts entirely to the baby, is what women are saying. And so they are overlooked and they are dismissed. Many women have described that they are not heard, they are not listened to, they feel disrespected. Sometimes they are even told, well, your blood pressure is so high when you're pregnant, stop having babies. I mean, who are we to tell women the number of babies they can have or to limit that reproductive right that women have? So it's not just a violation of women's rights, but it's also a violation of their dignity. Next slide, please. So if you look on this slide, these are some of the experiences that have been reported across the world. So you can see that women are not having a very good experience with preeclampsia itself. When they are pregnant, very limited education, they are not involved in their care. And when they even birth, it's much worse because here it's like, we are done with you and just move on and just enjoy the rest of your life. And so this is something that we have to look closely at. We have to listen to women and we have to just see how we can remodel care to better meet the needs of women. Next slide, please. So when I say that the postpartum period itself is a neglected crisis, what do I mean? The postpartum period is a high risk window, yet it is neglected. The risks are underestimated, and so opportunities for timely care are missed. Another thing is that we are discharging women quite early. If you read the WHO guidelines for postnatal contacts, WHO recommends the first visit within 24 hours, and then at 3 days, between 1 and 2 weeks, and at 6 weeks. But across the world, in many poorly resourced settings, women receive far fewer or none at all. Now, this gap reflects more than a failure of care. It reflects how we are deprioritizing women after birth. And if we want to improve outcomes in preeclampsia, then we really have to pay a very close attention to the postpartum period. Next slide, please. So why do these gaps persist? Why is this neglect still happening? Well, it also stems from that broader health system gaps in low and middle income countries. Postnatal care is fragmented. Guidelines exist, but they are not consistently implemented. And sometimes the guidelines are so outdated. Another thing is that workforce shortages currently across the world, midwives are in dire need. The ICM sort of like thing for this year is what? 1 million more midwives. We need more midwives. And so without midwives in these remote places, there's only so much that can be done. And also, like I said, symptoms are normalized, leading to delayed care and leading to more complications. Next slide, please. So then you would ask, Why does this matter? Why does this matter? Postpartum preeclampsia is not a clinical issue. It is an issue of justice. Women leave our care, but it doesn't mean we are done with them. And so if we do not follow them up adequately, if we do not make sure that they are safe and sound, then we are failing them. So that is something I want us to just think through and have a rethink about how we actually, you know, give postnatal care to women. Next slide, please. All right, so let us look at Ghana as an example. Ghana has a high burden of preeclampsia, and in Ghana, you can also tell that there are many gaps in postpartum care. I also want to acknowledge that it isn't all dark and gloomy. Ghana used to have a maternal mortality rate of about 714 per 100,000 live births. So you can see that there has been a downward trajectory. Considerable progress has been made. Currently, maternal mortality is about 319 per 100,000 live births. But there's still so much more to do to realize the sustainable development goals. Women continue to die, and it is quite disheartening. Preeclampsia is now a leading cause of death. But what is even more worrying is that a lot of mismanagement is reported in hospitals. So if a woman develops preeclampsia in Ghana, she's likely to have very bad outcomes. She's likely to die, and it's just becoming something that is beyond our control as a country. In Ghana, about 15% of women experience postpartum preeclampsia. So if you take 6 women, one of them will experience postpartum preeclampsia. So that means that our attention must really be drawn to the postpartum period. Next slide, please. So as I mentioned, preeclampsia continues to kill women in Ghana, and there are ongoing gaps in timely and effective care. We also know that about 1 in every 6 women will develop postpartum preeclampsia. But what we don't know is equally important. There is very limited Ghana-specific evidence on postpartum preeclampsia. And there's almost none on women's lived experiences. So if you Google postpartum preeclampsia research Ghana, nothing comes up, almost nothing comes up. So there's this huge gap that we don't even understand women's experiences. We don't know how women are monitored, how they are informed, how they're supported, and all of that. So these inequities that I've spoken about in the previous slides, they are not just experienced by Ghanaian women, but they are being what? Reinforced. Next slide, please. All right. So postpartum care in Ghana is delivered across the 5 tiers of the health system and is closely aligned with the WHO schedule that I mentioned. But many women do not receive all of these contacts in practice. In many cultures in Ghana, when a woman births, she's supposed to rest. So like, there's like a 40-day rest period where the woman is supposed to heal and bond with her newborn. And sometimes it limits her ability to come back for postnatal checks. And so it means that we have to find a way of taking postnatal care to the woman, to her community, in a way that is acceptable to her and in the way that makes sense. Next slide, please. Let's take a quick dive into the state of midwifery in Ghana. When we look at the workforce, there are both strengths, but there are critical challenges. Midwives work across the 5 tiers of the health system, so they are everywhere. In terms of education, the diploma in midwifery program is the more common option, and many midwives are diploma trained, but there are also BSc programs, and they are gaining traction in the country. The Nursing and Midwifery Council is a regulator, and so midwives require a license to practice. They require ongoing professional development to maintain that license. But a lot of midwives will tell you that there are very limited CPD opportunities for midwives in the country. But there are a lot of challenges midwives are facing currently. Low salaries, midwives are burnt out. There's a lack of motivation. They don't even know where to go in terms of career progression. So all of these things impact midwifery practice. But Ghanaian midwives are everywhere. That is the huge potential. That is the game changer. That is the lifesaver. Because they are everywhere, we can actually utilize them in postpartum care to make sure that women's lives are saved. So hold that thought again, because in the next slide, I ask, why midwives? Next slide, please. So midwives are the primary contacts of care for women. A woman may never see an obstetrician if she's pregnant, once everything is fine. But I bet you in that village, in that health center, there will be a midwife. So in practical terms, midwives can check the woman's blood pressure, they can recognize the warning signs of preeclampsia, and they can actually start the first frontline care that the woman needs, give her that life-saving treatment before referring her on. The statistics speak for themselves. 14,000 deaths can be averted with midwifery-led care. Because midwives, for us, it's not just about the clinical care, but it's about that respectful care, right? The communication, the shared decision making, making sure that we are actually giving women the care that they deserve, the care that they need, and the care that they themselves say they want. Next slide, please. All right. Let's imagine Sewa. Sewa is a Ghanaian name. So let's imagine Sewa just had a baby. She feels well. Her pregnancy was not complicated. Um, the next day, she's discharged home. But a few days later, she develops this very bad throbbing headache. She doesn't feel quite right. She assumes it's part of the recovery. She doesn't seek care. A few days later, she goes into a full-blown seizure and something nasty happens. But now imagine a different scenario. Sewa is supported by a community midwife. The midwife visited Sewa at home in the first few days after she had put to bed. She checks her blood pressure. She asks her simple but important questions. The midwife has recognized that Sewa is at risk of preeclampsia. So you just imagine how the trajectory can be so different. This is the impact of midwifery care. Midwifery care can actually change the outcome and can make sure that the woman's life is saved. So through regular monitoring, early detection and education, midwives don't just respond to complications, we prevent them. And we can empower women like Sewa to actually recognize the signs early and to take that life-saving action. Next slide, please. So if you look at low and middle income countries, you realize that midwives are trusted members of communities, and so they are able to engage better with women. At the same time, midwives also act as cultural brokers, and so even they are respectful of the woman's cultural practices. And so by taking the care to the woman, we are not violating anything. And we can also adapt. I've been seeing lately on Twitter how midwives in Uganda, in Tanzania, are visiting women, offering that mobile outreach services. And it is bringing life or life transforming change to women. And so we can harness all of these strengths. So like I said, women may not come into contact with a doctor, but will come into contact with a midwife. And what that midwife does could actually be the game changer. How can we support midwives to lead postpartum preeclampsia care? That is on the next slide. If we are serious about changing the outcomes, ongoing training for midwives is essential, not a one-off training, but ongoing, and that's simulation-based training. Just as important, we need to listen to women. At the systems level, the policies must change. The postpartum period must be prioritized. We need protocols for postpartum preeclampsia care. We also need updated guidelines. But none of this is possible if we are not prioritizing midwifery. Digital tools can help, yes, but we need the midwife to use the digital tool to complement her care, not to replace the care, because midwifery is about human connection. And it's not just about saying, oh, this woman is at risk, move her on to the next facility. The next slide, please. Next slide. All right. Okay. So in reframing pre-eclampsia care, especially in the postpartum period, we are saying that it doesn't end when the woman has a baby. We need to shift from that reactive to more responsive care. Instead of waiting for the emergency, the midwives can act early. So next slide, please. The call to action is so simple. Midwifery care has not really realized its full potential in the postpartum period. We need more investment. We need more education. We need midwives to be supported to do their work well. We need policy reform that is going to make sure that midwives can perform to their full scope. And that means that we also have to make sure that midwives have all the resources they need to be able to care for women safely. Midwives can bring care closer to the woman, regardless of where she is, regardless of her socioeconomic background, or regardless of the place where she's based. And so this shift is not optional. If we are serious about averting maternal mortality from postpartum preeclampsia, these are the four key things that we have to prioritize. If we get it right, then things will truly change. Next slide, please. So in reframing the research agenda, we need to actually have more research on postpartum preeclampsia. That is largely missing to date. We need to ask hard questions. Why are we missing women? Why are we doing too little, too late? And we need to stop asking questions about what is working. We know that midwifery works. So it's about how do we scale it? How do we make midwifery accessible to women all over to make sure that the real change that we desire is actually seen? Because if postpartum care is missing from research, it will remain missing from policy, and women will continue to be left behind. Next slide, please. So thank you very much for paying attention, for listening. And I'm so happy to hear from you, to take your contributions and any questions. If you'd like us to engage further, you can reach me on LinkedIn or send me an email. Thank you so much. And over to you, Bronwyn.
Thank you, Isabella. But I think you're still the star of the show for the moment. Oh yeah, Bupe, can you pop your question into the chat?
Okay, I also allow you to unmute yourselves if
Oh,
you'd prefer
perfect.
just to speak up. So,
Fantastic. Okay, well, our first question is Bupe. Please ask your question.
Thank you very much, Dr. Garti, for this beautiful presentation, which is very timely because I'm personally currently reflecting on pre-eclampsia management in Zambia because I lost my sister-in-law 2 days ago from postpartum pre-eclampsia. So she was diagnosed with pre-eclampsia antenatally. She was a midwife and had a cesarean birth 32 weeks, 2 weeks ago. And apparently she was having severe headaches. I wasn't informed about it, just learned of her death. And so how can we promote a community engagement of midwives in lower middle income countries like Zambia? So what is it that we need to do? Because just from the conversation when I was told about the headaches that she was having, somebody who's had a pre-eclampsia, then in the postnatal period, I knew that there was some problem with regards to how she was managed. So how can we strengthen this? How can we act today so that we can ensure that we are working towards prevention of preventable maternal deaths? Thank you.
I'm so sorry for your loss, Bupi. Like, I'm literally really emotional, and I'm quite sad that this continues to happen. We really have to do better. We really must do better, and we can do better. The thing is, I know that Zambia also has a lot of midwives. One of the things I wanted to say, but I was running out of time in my presentation, is that in Ghana, now we even have an oversupply of midwives is the problem. So a lot of the midwives are employed by the government, but there have been so many that have been trained. They are just sat there at home and they are descaling by the minute, waiting to be posted, waiting for a job. We can actually start community midwifery practices, let the midwives work through that primary healthcare model where they are based in the health center, the health post, the CHIPS compound. So this group of midwives can go out into the community providing this postnatal care. It really is that simple. This can be so hard to achieve. I also know that Zambia, just like Ghana, has a very strong lower level primary healthcare or preventive healthcare system. You have like morbidity nurses and preventive health nurses. They can work alongside the midwives. These women, we know where they live. These community health nurses know where the women live. They know the addresses. In Ghana, the address system doesn't work well. But because these nurses go into the community, they can go with the midwives. And then the midwives can take care of this woman. They can assess her, they can check how is the look here? Is she breastfeeding? Okay, all of these things. Because in this day and age, for midwives to be sat at home waiting to be employed, and then women continue to die on a daily, it's just unacceptable. We must shout louder. Our voices must be heard. Just before this presentation, I was looking at the Every Woman, Every Newborn, Everywhere strategy. That is saying 90, 90, 80, 80. What is the first 80? It says that 80% of new mothers and their babies must receive postnatal care within 2 days of birth. So this is not debatable. This is non-negotiable. Even if the woman has been discharged early because we need space for new women, that's fine. But as she goes into the community, who is going with her? Who is checking on her?
Mm.
And so, like, I don't even have the words to express like what this loss means. But I just want to say that we really need to do better, and women must be educated. We have to educate women as well so that they can speak up for themselves and they can seek care early.
Um, any other questions? Um, just noting, Bupe, you've added an additional comment in the chat, and you said the same problem exists in Zambia, that a lot of registered midwives are at home and not employed. So I guess I have a question then, like leading on to that as some, because in New Zealand we have, you can choose to be what we call a lead maternity carer. These are the midwives who pretty much they do the home births, but they either, they run their own practices. In a sense, they are independent contractors because they can send a bill to the New Zealand government. They work often as solo practitioners, but they do have people who will be their backups, or they work within larger teams, or you can work in the hospital. So just as someone who is, from a different system, can you explain why there is that barrier? Do registered midwives in Ghana have to work within a hospital setting or work officially like that?
Yes, a large proportion of registered midwives have to work in the government system. There are what we call privately practicing midwives, but that's like there are very few of them. It takes a lot to have a private practice. Currently, it's just like one midwife who will be operating that private practice on her own in liaison with like the hospital in her catchment area or that kind of thing. Most of these privately practicing midwives can only care for women who have, let's say, no complications at all. So once a complication sets in, we expect that this woman is referred on. However, postnatal care oftentimes is not very hospital based because, like I said, many women may travel to seek good quality care, but once they have the baby, they travel back. And so she was referred from a different point A to point B. She's had a baby in point B, she's going to go back to point A. So how can we make sure that even if she goes back to point A, she still receives some sort of continuity? That's what we are saying. So in places like Ghana and Zambia, the process is a bit different, and it's really, really hard to even get accredited to be a privately practicing midwife. And they don't operate like a caseload model like we see in places like Australia or in New Zealand. It's quite different. It's just a midwife giving more or less antenatal, postnatal services. A few of them give birthing as an option, but in times past, there have been lots of legal issues. And so we are fading that private midwifery practice away gradually, and it's becoming fully like a government-owned model of care. And so there's a potential for us to have like a full midwifery-led model of care because in the lower level facilities, and I've also worked in lower level facilities, there's really no doctor. So the midwives can operate like a full MGP, but currently in Ghana, it's sort of like a team-based model. So a group of midwives will be caring for like a cohort of women. And when she goes into the birth, it's a different team of midwives who will care for her, postnatal, a different team, but then it ends because we don't really have community midwifery. We don't do that community midwifery follow-up. But that is what I want to bring attention to, that if WHO is prioritizing midwifery-led models of care, we need to go full scale. We need to really make sure that we are doing the right thing and making sure that along the full trajectory, up until the 6th week, this woman gets quality care.